So yeah, want to talk a little bit about what's going on right now with COVID-19 and what might happen in the future with it. And I always like to start with the worldview of the pandemic. So here is pandemic across the world. We are closing in on, unfortunately, 5 million deaths from COVID over the course of the pandemic, with 244 million confirmed cases of COVID-19. The good news that I always like to point out is that there have been at this point almost 6.7 billion doses of vaccine that have been administered across the world, which is pretty incredible when you think about that. You can see some of the hot spots here in the darker blue colors, including, unfortunately, the United States. Russia is having issues right now, India, and then, of course, part of South America as well, including Brazil. So still some hot spots across the map. And then in the United States, we've had over 45 million confirmed cases at this point, and over 700,000 confirmed deaths since the start of the pandemic. It's always interesting to look at what we call the epi curve of the pandemic. And you can see the different waves that we've experienced. So the initial wave back when COVID was really emerging in April of 2020, and we had a summer wave in Florida, and that was reflected across the US as well. The winter wave that we had come through. There was a little bit of a spring uptick in the US. We didn't really see that in Florida, though. And then, of course, the more recent Delta wave that we did have a bad experience with in Florida. And then looking at deaths, you can see that there's a little bit of a odd thing here where you have a lot of reported deaths without that many reported cases. And this is really because mainly the people who were getting tested at the time were the ones who were severely ill. And so this is, in particular, this stands out as having a high level of deaths compared to maybe cases, but it's a little bit of a function of what was happening with testing at the time. So in Florida, COVID has been decreasing over time. So we were really at our peak of the Delta wave toward the middle of August, and we have come down nicely from that. And actually, I want to show you our next slide because it shows you the pandemic across the Delta wave. So again, this is an epi curve showing you the number of weekly cases for each of the weeks beginning with this date. So here's our most recent data of 15,000 cases. We're back similar to where we were at the end of June. So in much better shape than we were just a couple of months ago. And then the new case positivity, we've also seen that case positivity drop as well. We'd definitely like to see that at least under 10%. We're now under 5%. So that is an encouraging statistic. Keeping in mind, though, that we do still have transmission in the state. So this is showing you what's going on right now in the state. So this is CDC data, and CDC looks at areas of what they call high in red, substantial in orange, moderate in yellow, low in blue transmission. And with apologies to anyone who is not able to see colors the same as all of us, but what we can see is that there are a few counties that I'm pointing out here that are still some high transmission counties. Much of the state, though, within the past month has come down to substantial level of transmission. Now, CDC does recommend that anyone in a high or substantial area of transmission continue to wear a mask indoors, regardless of vaccination status, just because of how many cases of COVID-19 there are in the community. High transmission means that you are above 10% positivity for the past 7 days, and or you have more than 100 cases per 100,000 population in the past 7 days. And it's really that second measure that has been keeping some of these counties in that high transmission state. For substantial, it's anywhere between 50 and 100 cases of COVID-19 over per 100,000 population over the past 7 days. So you can see that a lot of the counties in the state are now at that point, and we're actually continuing to decrease. We're seeing more counties come into this moderate category, and even one category that's dropped into a low. I expect that most of our counties will get into the moderate category within the next 2 to 3 weeks, and some even into the low category. So we're definitely on the downside of that peak that we had with Delta. And then hospital occupancy, as you can see here, this is from Florida Hospital Association, comparing their 2020 hospitalization data, which is in blue, to their 2021, which is in red. If you look on the y-axis here, we've got the number of hospitalizations. And sorry, it's very hard to read, but on the x-axis, we have the dates starting from June 1st and going through, starting from June 1st and then going all the way through October 22nd. So really looking primarily at the summer peaks. So we've definitely seen that in this 2021 peak, we had much greater hospitalization rates than we did last summer. We can also see that last summer's peak began a lot earlier than this summer's peak began. This last year was really probably largely due to us coming out of stay-at-home orders to really opening up again and not having vaccine access. Whereas here, we're really looking at the emergence of the Delta variant and people not being vaccinated, but that being so much more transmissible, or sorry, not having full vaccination. We had some people vaccinated, but this being much more transmissible variant. Tripping over my words, my apologies. And so a little bit about the projections, what's going to happen now. So this is data from a group at our Emerging Pathogens Institute, and they've been doing projections really throughout the pandemic. And what's shown here are in black are the reported cases. So that's what's actually happening. And then in yellow, they have the modeled reported cases. So that's a prediction of what is going to happen. And you can see that these have matched up really nicely. I had downloaded this several months ago, and the prediction was really looking like it was spot on with what wound up being reported. And so now you can see the new predictions here from beginning of October, through our holiday season or winter season. And so we're going to see a continued decrease in cases of COVID-19. And the projection is that should stay low. There may be some potential blips in cases over the holiday season because people get together more, they travel more, but we expect this to stay fairly low into January. The caveat that our researchers give, though, is that in the spring, we may see another wave, and that could be due to another variant that has not yet been identified. And so we always have to worry about what's coming around the corner and not get too relaxed. But at least for now, we look to be in fairly good shape. I always say that, you know, I'm careful about these projections because a lot of times when we see that, we think we're in the clear, we're okay, nothing else is coming, and we let our guard down. And to me, that's worrisome because it's when we let our guard down that we wind up seeing cases go up again because people naturally want to get together. They want to be without masks. They want to, you know, get rid of those precautions and go back to normal. So I just always ask people, please keep an eye on the cases, keep an eye on what's going on, you know, make yourself an educated consumer of the data so that you can be really aware of whether or not you need to be taking precautions because cases are on the rise. Okay, Philip, do we have any questions so far?
We do not have any questions as of now.
Okay,
yeah,
great.
But yeah, if anyone does, feel free to type those in, yeah.
All right, so I wanted to move on to the COVID variants. There are a couple categories of variants that the CDC, actually both the CDC and the World Health Organization use. I'm focused here really on CDC, but there are variants that are being monitored. So these are variants that are currently within circulation within our population. They're not variants that we are especially worried about, but they're ones that we're keeping an eye on. So you can see there are quite a few. A few of them you may have heard of more recently. In particular, I think a lot of people have been concerned about the Mu variant as something, the Mu, as being something that's circulating within other countries and then potentially could be causing concerns here. We're not seeing that right now. We're not seeing that as a major issue. And then there's also the variants of interest. So variants of interest are variants where there may be some sort of genetic change in that variant that we can identify, so a genotypic change, and that genotypic change gives us pause and makes us think, you know, that could be related to either increased spread of that variant, to increased severity of disease associated with that variant, that maybe the testing won't be as effective against that variant or for that variant, that maybe the vaccines won't work as well against that variant, or that some of the treatments may not work as well. So that's what a variant of interest is. It's more that you're seeing genetically that there's something that you could be worried about, rather than seeing that the phenotype or the actual virus in the population is really causing a concern. So variants of concern then are, you can imagine, it was a variant of interest, you know, there was something about it that we were worried about, and then it got into the population and we realized that yes, it really is acting in a way that makes us worry or makes us have to be worried about it being more severe, more transmissible, any of those other things I had mentioned. And Delta obviously was one of these. Delta was much more transmissible than the other variants that we had seen, and really seems to be associated with more severe disease as well. Right now, luckily, that's our only variant of concern, but again, that's on the radar for people to keep an eye on. And these variants, I didn't really include this here, but what happens is people are doing molecular epidemiology on these variants. So they are sequencing some of the variants that they're getting from positive tests. They're looking at that genetic sequence, and then they're also uploading it to a large database that's publicly available. And so then they can use that in order to identify what's an emerging variant, to look at some of these genetic areas of interest within the variant, and to hopefully predict what's going to be coming around the corner. And then finally, a variant of high consequence. We luckily have not had these yet, but a variant of high consequence would be something that was so different than what we've had before that our tests really would not be good at identifying it, that our vaccines would not be effective against it, our treatments wouldn't work on it. And so obviously we can understand why that would be called a variant of high consequence. Luckily, as I said, we have not dealt with that yet. So looking at the different variants, it's been interesting to see how Delta came in and took off. So what I'm showing you here are percentages of the different types of variants that we've had over different periods of time. So this slide, we start from February 27th of 2021, and it ends in the week of May 8th of 2021. I'm pointing out the B117, that was the alpha variant. You may be more familiar with some of these other designations at this point. This other variant here was the iota variant. Some people have been concerned about that as well. At this point in February, we didn't have any of our Delta variant. What we saw really was alpha variant just growing and growing within our population. And alpha had been about 20% or so more infectious than some of the other variants that we were encountering. So you can see how quickly it took off over a fairly short period of time to where it became the dominant strain of COVID-19, or dominant variant, sorry, of COVID-19 within our population. So to remind you, that ends on May 8th. And then I'm picking up here on May 29th. And so here's alpha again, this time it's in blue. Sorry, I didn't change the colors, but CDC did. So this is alpha in blue, and now we see Delta starting to pop up. And it's pretty amazing that from the end of May, and here we have the end of August, and over this period of time, Delta just took off. It's pretty incredible to see it, how it became such a dominant variant within our population. And if we take it a little bit further, so that was ending at the end of August, and that's picking up right here. I wasn't able to separate that out completely, but you can see where we are now. This is the most recent data I was able to get, but we are still just very much dealing with the Delta variant in our country. I mentioned mu before, that some people had some concern about that variant. We're not really seeing any issue with that at all. About 0 to 0.2% of all of the isolates that are sequenced are the mu variant. So it's just not overcoming Delta right now. So I'm going to switch gears a little bit because we've had a lot that's happened with vaccines within the past week, actually, and is still going to be happening over the next week. So I wanted to address that. So the big thing I think that's happened is the COVID-19 vaccine for children ages 5 to 11. So I think most of us know that right now there is full approval for the Pfizer vaccine for those who are over 18, and there's still an EUA for children who are who are over 16. There's EUA for 12 to 15, emergency use authorization. And now they're looking at vaccination and emergency use authorization for children who are ages 5 to 11. So the FDA advisory panel met this week, and they did approve this Pfizer vaccine for kids aged 5 to 11. The next step is this will be reviewed by the FDA, and I expect that probably to happen by the end of the week. They're usually pretty quick at doing that after their advisory panel has reviewed it. Typically, they are following what the advisory panel has recommended. We'll see if that happens. It's not always a given, but likely, I think the FDA is going to also want to approve this. And then the CDC advisory panel, that's the Advisory Council on Immunization Practices, or ACIP. They're going to look at this next week. They meet on the 2nd and 3rd, and so they'll also make their recommendations. Again, typically they follow what the other groups say. That's not always true, though. But I think we expect that they probably will also recommend this for kids age 5 to 11. So the dose for kids is 1/3 of the adult dose. So it is a lower dose for children age 5 to 11. The dosing, what I see is mainly people saying, this is based on the age of your child, not on the weight of your child. So I've seen a lot of questions of, if my child is 11 now, but they're going to turn 12 in a month or 2 months, should I just wait and get them an adult dose? I'm not a physician, so I definitely recommend that people always talk to their physician about decisions like that. But I can also say that, it's said often that children are not little adults. This dosing is based on age, and really if someone's going to get their child vaccinated, rather than wait, the recommendation is to go ahead and do it, and go ahead and do it with the age appropriate vaccine for your child. So if your child's 11, go ahead and get this vaccine for 5 to 11-year-olds at this 1/3 of a dose. It was shown to be very effective in that age group. They're mounting a good immune response, and there's no need to worry that it's a reduced dose or to wait longer for them to turn 12. Side effects similar to those of adults, maybe even a little bit less severe as far as just the general side effects that many of us experienced with vaccinations. So sore arm, fatigue, fever, that sort of thing. There were no vaccine-related adverse events in the clinical trial, so no major events in the clinical trial that were associated with the vaccine. It was, not a huge number of people enrolled in the clinical trial, so it is possible that there could be adverse events that we're just not aware of yet because we didn't have that large-scale group of people enrolled in the trial. And in particular, we worry about some of these episodes of myocarditis that we've seen with other vaccines. And that is also associated with COVID infection. But, just to say that just because they weren't seen in this clinical trial, it doesn't mean that that's not a possibility for kids as well. In fact, I think a question. So question is, I have grandchildren that are above average in height, but very thin. Check with doctor, correct? Yeah, so, again, I would say that really it should be based on age rather than on height or weight or anything like that. And, everything that I'm reading is, that the children's immune systems tend to change after puberty versus before puberty, and that they mount a really good immune response, in particular when they're younger. And so that's why that smaller dose is really effective for the younger children. So I wouldn't be concerned about, oh, they're not getting enough of a dose, or it's a larger child, just a child who's ahead on the growth curve. But absolutely check with pediatrician, because I like to be mindful not to be giving medical advice myself, since I'm not a physician. So vaccine boosters and third shots, and actually today I was even hearing about fourth shots. So moving on to that topic, oh, we have another question. Sorry, I should probably pause and see if any other questions are coming in. Not seeing anything right now. Okay. So third dose and booster doses has got a little bit of confusion, especially when it came out. So I just want to go over it so that we're all kind of on the same page terminology wise. So a third dose is a third shot of vaccine for someone who may have some kind of underlying immune condition that when they got the 2 original doses of their vaccine, they still didn't respond as well as someone who has a fully competent immune system. So that third shot is really meant to be another attempt to get your immune system to what would be a full response for anyone else. And what I'm reading now, again, is that there are some cases where people may be actually offered a fourth shot. And people who were getting these booster doses, in particular, who were maybe having active cancer treatment, and their immune system was compromised because of that, so it couldn't respond as well to the vaccine. People who are on immunosuppressant medications because they've had either a solid organ transplant or they've had a recent bone marrow transplant. People who have corticosteroid therapy, that they're doing that, especially longer term, steroids suppress your immune system, or people who are on medications that are meant to suppress their immune system. There are folks who have things like rheumatoid arthritis, multiple sclerosis, or Crohn's disease, and often the medications they take also suppress their immune system. So those were some of the folks that were eligible for those booster shots. And again, as I mentioned, it's looking like there may be a possibility of them even being offered a fourth shot. Or sorry, I said boosters and I misspoke. They were eligible for third doses, and they may be offered a fourth shot in the future. So then the other part of this is, what's a booster? So the booster is for folks who are expected to have a normal immune response to COVID-19 vaccination, but it's been a while since they've been vaccinated. So their immunity may be weakening. It may be time to remind their immune system of what this COVID-19 spike protein looks like, so they can respond more quickly if they encounter that, if they wind up getting infected. So the third dose, what I should mention is that people are eligible for a third dose 30 days after their second dose. A booster, that would be someone who is 6 months out after their second dose. So it's for folks who generally were fully vaccinated January, February at this point. Let me see, March, even April getting towards. So people in that earlier wave of folks who got vaccinated, it's been 6 months, and they feel like they're concerned that they may have weakening immunity. In particular, that is approved for people who are over the age of 65. Let me see, I think I'm getting ahead of myself here, sorry. Yeah. So these, I already mentioned the third shots available for people who may be moderately or severely immunocompromised, and that's already approved. The third shot the booster shots, even I get messed up. This is why I like to go over the terminology. The booster shots are included in the emergency use authorization for both Pfizer and Moderna. So those are for people who are 65 and older, people who are 18 and up and live in a long-term care setting, people who are 18 and up and have an underlying medical condition that may put them at higher risk for severe illness with COVID. We know that's people with diabetes, hypertension, obesity, and some other conditions as well. And then people who are 18 or over who live or work in a high-risk setting. So all of those folks are eligible if it's been 6 months since they got
Dr.
their,
Prince, we
second
have one
dose.
question,
Yeah.
and it's on the topic of natural immunity after contracting the disease,
Yes.
excuse me, and how long that lasts.
Yeah, great question. And unfortunately, it's not something that we know a ton about yet. So I think we're learning more and more about the effect of natural immunity. Um, I can tell you that from a surveillance standpoint, well, let's start with just natural immunity. Yes, you do get an immune response to COVID-19, and there is some amount of time that that immune response is going to be protective of you getting reinfected. Now, I have seen people get reinfected as early as 2 months after they just had a COVID-19 infection, but it's actually really for the general public expected to last longer than that. From a surveillance standpoint, we kind of give people 3 months. So, we say if you had COVID-19 within the last 90 days, we're not going to consider you to be positive again if you happen to test positive for COVID-19. That's in part because you may continue to have some of that messenger RNA in your nose or your mouth where they're testing you if they're doing a PCR test. That may linger. It may not be an active infection anymore. It's just lingering. And so we don't want people to have to continue to isolate if they're really not infected. But it's also because of that period of time that we think people are going to be protected. Now, that's 90 days, but yes, we expect that to be a little bit longer. It's looking like probably at least 6 months for a lot of people and potentially longer than that. Now, the caveat is we never think of an all or nothing protection, right? So when we talk about getting vaccinated, you are getting exposed to COVID-19 and then you're getting boosted 3 or 4 weeks later. So you're getting another exposure to make sure your immune system really builds up that full immunity to protect you. And now we're talking about more boosters. If you get infected with COVID-19, you get that immunity, but you're not getting that booster or that next booster unless, unfortunately, you get infected again, which we're wanting people to avoid because you still can get severely ill even the second time around with COVID-19 infection. So for people who did have COVID-19, it really is still recommended to at least get a dose of a vaccine. Go ahead and get vaccinated. You can get vaccinated. The minimum is they like you to wait at least 2 weeks after you had COVID-19. Here at UF, we typically have people wait about a month after they were infected, but there's definitely a benefit still to getting a vaccine on top of having had COVID-19. Hopefully I answered that, but if I didn't, please let me know. And then the next question is about mix and match vaccines. And this has been new as well. And it really came up, I think, in particular because of the Johnson & Johnson vaccine. And what we saw during the Delta surge was that people who had gotten that 1-dose Johnson & Johnson vaccine were not as well protected against Delta as folks who had gotten the 2-dose Pfizer and Moderna vaccines. The Johnson & Johnson had only been approved as a 1-dose vaccine. So even at the point of Delta, it wasn't approved for people to get a booster of that vaccine. So now Johnson & Johnson has gotten approved as a 2nd dose. And then the other thing is that people can actually mix and match their vaccines. So this was another study that's been done recently looking at whether getting a different type of vaccine for either a booster dose or for a 3rd dose might give you better immunity or better protection. And it looks like that may actually be possible. So individuals are now allowed to choose which vaccine they want as a booster. So for example, I got a Moderna vaccine initially. If I go get a booster and I decide that I want a Pfizer vaccine, then I'm allowed to do that now, whereas before that would not have been permitted. But there are no current recommendations on which one to get. So this is one of those difficult things where we tell people, hey, this is available to you, but we don't really tell them what to do. I think the important thing is to, if you want a booster, get the vaccine that is available to you. So, don't necessarily hunt around for a different vaccine. I don't know that there's a lot of benefit in doing that. Even with the Johnson & Johnson vaccine, they're showing that if you have a second dose, you actually do build up very nice immunity. So you don't necessarily need to switch doses. Your side effects should be fairly similar to what they were before. So, if you had, let's say, a Pfizer vaccine, you had pretty minimal side effects, you felt okay with it, then, think about getting Pfizer as your booster because you already have experience with that vaccine. It's something that hasn't bothered you. So not a lot of guidance there, but really the idea is, go with whatever had worked for you before potentially and go with what's available to you. See, and there is evidence that any kind of booster is going to be protective, as I mentioned, so especially protective against getting hospitalized or dying from COVID-19. So I'm going to switch gears a little bit now from vaccine, which is prevention, to some of the treatment options if people have gotten infected with COVID-19. So we've had monoclonal antibodies available for quite some time now, and these are pretty effective at helping people when they've already been infected. So we always like to say, get vaccinated. That is really your primary way of protecting yourself from not getting COVID-19. It's really important to do that. The monoclonal antibodies are sort of a second protection. So, we've seen breakthrough cases. We've seen people who got vaccinated, who got sick. I had an experience with a friend a couple of weeks ago. She was vaccinated, but she got a breakthrough infection. She had some risk factors that could have made that severe, maybe not enough for her to get hospitalized or die, but still to get very ill. And she did go and get monoclonal antibody treatment. She was eligible to do that to try to help tamp down that infection a little bit. So these monoclonal antibodies, when you get vaccinated or if you have COVID-19, you do produce antibodies. But the thing is, it takes some time for that to happen, especially if you've not been vaccinated. And so the idea about monoclonal antibodies is they've been produced in the lab. They're packaged already as something that you can get injected with that can get to work immediately on trying to tame that COVID-19 infection that's now going on inside your cells. And so these antibodies are going to target the spike protein. That's the same thing that you're going to build antibodies to if you get infected, no matter what, or if you get vaccinated. But again, it's sort of, you're giving it at an earlier time. You're getting these antibodies into your system at an earlier time to hopefully make that infection not so severe for you. So these are approved. They are emergency use approval also. So they are not fully approved yet, but they are shown to be safe and effective. There are 3 different options, and I'm not going to do the gymnastics of tripping over all of the names, but you can see them here. The first one, and what I want to point out, actually, one thing is, these names are tongue twisters, but if you look at the end, they all have MAB on the end, and that just means they're monoclonal antibodies. So kind of right in the name. The first one, there's a combination of 2 different types of antibodies. In some states that is paused currently because it may not be as effective against a couple of the variants that are circulating in those in some states, so gamma and beta variants, but these are available in Florida. We're not seeing an issue with those variants. So that's one option. There's also Regeneron, which some people have heard of, and then Xevudy is another one. And if you go on the Florida Department of Health website, you can find sites that will give monoclonal antibody treatment. Treatment should begin as soon as possible. So for anyone in particular, if you have risk factors that may make you more susceptible to bad outcomes with COVID-19 infection, as soon as you test positive and you're having symptoms, that's really the time to go and seek this treatment. Treatment is free, so that's important to know. It does give a 70 to 85% relative reduction in hospitalizations or death compared to placebo, so it is effective. It's not 100%, keep that in mind, but it is effective. It's under federal government distribution now, and it is, as I said, not a substitute for vaccination. It's really just an extra tool. So again, recommending get that vaccine, but if for any reason you get a breakthrough case or something else is going on, this is an option. These are typically administered either as an intravenous solution or as 4 subcutaneous injections. And then you'll have to stick around for about an hour just to make sure that there's no allergic response, which is extremely rare as it is with the vaccines. Okay, and then this is, let's see if we have let's see, where do you go to get monoclonal antibodies if eligible? Yeah, so there are distribution sites for each of the different areas in Florida. So I'm in Gainesville, and our distribution site is actually up in High Springs. There's a church site where they're distributing it. So I would say definitely go to the Florida Department of Health homepage. When you go on that homepage, they do have a locator for monoclonal antibody treatments. And then when you click on that, you're going to be able to select your own location and find the nearest site. I recommend calling them. When my friend was ill, she called them and they said, we're walking, you can come on by during any of the hours that we're open. I don't think they're as busy right now as they were during the height of the Delta wave. So I would still call in advance and just make sure that they're going to have that available for you and what their criteria are. But again, she was vaccinated, fully vaccinated, but she was still eligible for that. Molnupiravir is a new antiviral. So again, I gave you the hint on the MAV. If you look at VIR at the end of a drug name, that's typically, or AVIR is going to be an antiviral drug. So this is a new treatment, and it is for very early stage COVID-19 infections. So 5 or less days of symptoms. So again, you need to be very aware that, you're symptomatic, that you're potentially at higher risk, and then go seek this treatment if you're going to want to use it. It is an antiviral pill. It's taken 2 times a day for 5 days. It's actually a high number of pills. I think you're taking 8 per day. It's quite a few. So what we know from the clinical trials is it showed about a 50% reduction in hospitalization compared to placebo, and that there were no deaths in the group that took this drug versus 8 deaths in the placebo group. This is not yet approved. There is an EUA that is expected by the end of the year. So this is not quite available yet, but it's coming down the pipeline. It's expected to be free of charge. This is something where you would be getting a prescription. So it's quite possible that you would need to go see a provider in order to get this, rather than just being able to go to a site like you can for the monoclonal antibodies without a prescription, but I'm not 100% sure of that yet. Concerns potentially about whether pregnancy could be a contraindication. So the way this drug acts, it's what we call a ribonucleoside analog. And so it's meant to look a little bit like an RNA base. So when COVID-19 is copying itself, it's adding new RNA bases to its chain to make a copy of its own RNA. So it can keep producing that, keep making the proteins it needs to continue to infect your cells. This analog means that it looks like an RNA base, but it's not quite an RNA base. And what happens is it'll get added to that RNA chain as it's growing, but it'll wind up making it basically full of mutations, that it's not going to be able to be an active RNA. It's not going to be something that the virus is ultimately going to be able to use for its own functions to be able to copy itself and continue the infection. But the concern there is that in this case, you are, adding these analogs, and for a developing fetus, is that going to be a concern as the fetus is growing and also carrying out a lot of cellular processes that may involve RNA. So possible that's going to be a contraindication. I don't know yet where they're going to go with that, though. Again, I would go back to vaccination, though, in particular for pregnant women. We saw a lot of really sad stories about pregnant women who, in particular, were not vaccinated, who got infected with COVID-19. And either, they had bad outcomes and they got very ill, even died, or a few cases where the pregnancy was lost. So we know that vaccination is very safe for both pregnant and breastfeeding women. And that's what I would encourage, rather than looking at some of these treatments, which are a little bit more a little bit more concerned. So question is, do you get an antiviral from your doctor? So yeah, I mean, typically that's what happens right now. So for example, there are antivirals against flu, right? If you wind up getting a case of influenza, they might prescribe an antiviral for that. So that is a prescription only. So you would need to see a physician to get that. And the expectation is it would be the same for Molnupiravir, that you probably will need a physician's prescription. And I did want to talk about ivermectin, since I'm talking kind of in the realm of treatments. So generally, just talking about what ivermectin is, I know this has been in the news a lot, with a lot of concern, honestly, about people taking this and with it not being a proven treatment. And honestly, it's not a proven treatment. It's not something that works against COVID-19. So there is concern about people taking it. This is an anti-parasitic drug, typically used for things like roundworm, river blindness, and head lice. It is very inexpensive, and that's why it was originally investigated, because it would be very nice if there's a treatment like this that would be available to people, in particular internationally. Ivermectin is in wider use in other countries just because people encounter more parasites in those countries than we do in the US. We tend to use it for agricultural animal purposes. But it would be great. And sometimes there are drugs that can be repurposed. So this is an anti-parasitic. A parasite's different than a virus, but it was worth exploring to see whether or not it could be useful. So in vitro, in a petri dish, it showed some possible effects against the SARS-CoV-2 virus. That's always a first start when things are being tested. When drugs are being tested, you start in that cell culture to see what's the effect. But from there, you go usually to animal studies, and then you would go to human studies. So by the time they got to human studies, there were some small studies here and there. Conclusions were mixed on whether or not it worked. There was a large clinical trial that was done in Egypt that showed effectiveness, but unfortunately there were major ethical concerns about the data. So it looks like there are problems with the data, potentially being fabricated, just patterns in the data that don't look right, plagiarism within the paper. So there were a lot of accusations about this trial in particular that was really being used to support use of ivermectin. There was a large multi-partner clinical trial conducted in Brazil, and that showed no effect whatsoever. So I just want to emphasize this again, because my concern is that people are taking this feeling like they are getting protection and they're not. There are other protections. Obviously I promote vaccination. I believe in the vaccine. I believe it's the best method for prevention. But, for people who are not getting vaccinated for whatever reason, those monoclonal antibodies are still there. We know they work. So I just want to point people toward the things that we know work, and away from things that are just not going to be effective for them. And then finally, I just wanted to talk a little bit about some of the messages for, your own constituents, or even, family members, the people around you. I think that the public has been really great in being able to often counsel other people, and, here's the good science. Here are the things that I know that are effective, and really spreading that message for people, and often, countering some of the false messages that we've seen, in particular in social media. So messages, number one, get vaccinated. Very safe, very effective. I mentioned, billions of people at this point have been vaccinated, hundreds of millions in the US. So, this vaccine has been out, or these vaccines have been out for nearly a year now. We're not seeing major problems with them. It's really good safety. Wear a mask indoors while you have, in particular, high or substantial transmission, and especially around people who are unvaccinated. Folks who are unvaccinated who are infected are more likely to transmit. And if you're unvaccinated, you're just unfortunately also more likely to get COVID-19. So for folks who are trying to prevent a breakthrough infection, continue to wear a mask indoors for now if you're in one of those higher transmission areas. staying home if you don't feel well, this has been sort of a major change for people. We've had this culture of going to work when we're sick, no matter what. I can't afford to stay home. I can't afford to, take a sick day. And I think we've got to shift that mentality and say, you know what, at this point, we've got lots of methods to be able to participate if we need to while not being in the office. I know that may not always apply to our audience who are often needing to be in the field, but the idea here is let's take those sick days. Let's actually take care of ourselves, stay home, and encourage others to do the same if we don't feel well. Get tested if you have symptoms. There are a lot of folks, and someone's saying, thank you for saying this. Yeah, none of us like to be around someone who's coughing and sneezing and sick anyway, but I think, just for our own well-being, it's good to stay home and heal. Get tested if you have symptoms. So we've got a lot of things that are going to be circulating, especially in our winter months. We do have influenza again. Definitely recommend getting a flu vaccine to protect yourself from getting sick with that. True influenza, I don't mean stomach flu or a cold that some people refer to as flu. True flu is a really nasty infection as well. And it can be very severe for some folks, especially for our older folks and for children, but also for people with certain underlying conditions. I have asthma. I get a flu vaccine every single year. I always get it. It's really important. There are other things that are going to circulate as well. It's always worth getting tested, though, to see whether or not you have COVID-19. If you're high risk, think about that monoclonal antibody therapy as soon as you know you have COVID-19. Again, just trying to protect yourself from getting a real severe case of it. And then, as mentioned before, pregnant women should get vaccinated. There's no harm to a developing fetus or to a breastfeeding baby. And in fact, what we're seeing is that when women get vaccinated when they're pregnant, their baby actually does retain some antibodies that retain some protection from mom getting vaccinated. Those antibodies can come through placenta, through breast milk. So it gives baby some protection against infection as well, which is really important. Okay, that is what I have. Are there any other questions that I can answer?
Dr. Prins, while folks are thinking about questions, I'll go ahead and ask one, and then of course, as they come into the chat, we can get to those as well. But going along with your last slide there, as far as messages for constituents, what would be your message for those that are thinking, hey, look, infection rates are going down. Why, if I haven't been vaccinated, why should I now get vaccinated? Or now my children are newly eligible for a vaccine that they have not been eligible for, or they will soon to be. Why should they be vaccinated if infection rates are going down? What would be your response to that?
Yeah, absolutely. I think that's a great question. So, response to that is yes, infection rates are coming down, but we still have COVID-19 circulating within the community. So even when those rates come down, we have to understand that infection rates are actually going up in some other parts of the country. So we went through that wave Delta wave a little earlier than other places. We are open, traveling, interacting with each other. So just because it's coming down, it doesn't necessarily mean that you're not going to encounter and get infected with COVID-19. So that vaccine is still really critical to protect you, protect your children. And then the other thing I'd mention is that the process of building immunity through vaccination takes some time, right? So for example, if you're getting a Pfizer vaccine, you get your first dose now, but then you have to wait 3 weeks to get your second dose. And then you have to wait 2 weeks to really develop full immunity. So at this point, you're 5 weeks out from full immunity. We saw with Delta how quickly those cases rose, how fast that variant took over. And so my concern is when people hesitate, they're waiting, they're not getting vaccinated, they're not giving themselves the protection they need now against a future variant. And I think that is really critical because what's happening around the globe is that not every country has been able to lower their cases or get as many vaccines out as we have. Again, we're all one big global community. Travel, you can get to, the other side of the world in less than a day. And so those variants come from other places. They are going to spread very quickly when they get here if they're another very transmissible variant. So the idea is get that protection now while you can. Don't wait for the next Delta wave to go up. A lot of people got caught unaware, and unfortunately, we had a lot of people who died because they kept waiting to get vaccinated. Let's see. Any other questions? Let's see. What are recommendations for worker groups and worker safety? Any comments on OSHA's new rule for vaccinating employees? Yeah, so I think as far as worker groups and worker safety, I definitely, again, I say, get vaccinated because in particular, people who have to work in close quarters, you're going to interact a lot. It's hard for a lot of people to really maintain those infection control practices all day long, of wearing a really good mask or double masking or even wearing an N95 all day. People let their guard down after time. And so, you wind up getting exposed to each other. Trying to let's see, what was the second question? Was OSHA's new rule for vaccinating employees. I am not familiar, I apologize, with what their new rule is. I'm assuming that is that requiring vaccine? Can you clarify for me? Not getting clarification there. I may have to get back to you on that one, and I apologize for not being familiar with that. Here we go. Thank you. So they're creating a new employers with 100 or more. Okay, so as the same with the federal mandate. So again, because I believe in the vaccines and believe in how effective they are, and because we now have vaccines that are fully approved, and we are in the midst of a pandemic that is very disruptive to people's lives and to businesses as well, I do think it's important to mandate vaccines. We do this with all sorts of different vaccines. We've done this for a long period of time. And in fact, this is the reason that we get to be so comfortable with so many things. This is the reason that you don't worry day to day about polio or worry day to day about measles even. And that's because of vaccine mandates that help us get enough vaccination within a population that, at least in this country, we're lucky enough not to have to worry about some of those things. So, I feel the way about COVID-19. It is a really good vaccine. I'd say, in fact, it's much better than our typical flu vaccine, which I already told you I still strongly believe in. And so I think it is important for us to kind of be able to return to normal, whether it be in a workplace or in our personal lives, to start getting people vaccinated and to mandate that as needed.